And I think the last discussion that just was had is illustrative of the impurities of pressure volume loops in clinical care. So I have no disclosures. And, I trained as a pharmacologist, and we had one of those nerd pharmacology statements where a physicist can make a line with 1 point, a physiologist can make a line with 2 points, and a pharmacologist needs at least 3 points to make a line or a dose-response curve. And then I sat in Dr. Burkoff's Teach Symposium yesterday, and I watched his pressure volume loops. And I'm going to tell you, I'm not going to show any pressure volume loops because you just saw the expert. But pressure volume loops are clearly much more than a line. They're a dynamic and responding to physiologic variables all the time. And the question is, can they provide us with any information that is clinically useful in the bedside? And there clearly are studies looking at both echo parameters and creating pressure volume parameters out of echo that have been shown in clinical studies, but not in the acutely ill cardiac patient. So I went looking for quotes about shock, and this is the one I found, is that shock can kill you. Shock is terrible, but what you've got to do is to live in the present, which is what I have always done. And this is from a woman who is a fashion designer, and I have to say I don't really understand why her life was so crazy. But what we do as clinicians, and I am an interventional cardiologist, I actually am actively involved in our acute mechanical circulatory support, both initiating ECMO, Impella, and all the other support systems. And what we do is we walk into the bedside of the cardiac cath lab or in the cardiac ICU, and the situation is what it is. The patient is stormy, it's deteriorating, and we walk into this. And then the question is, do any of the definitions that we have for shock help define either our practice or our protocols? And I think what we've seen in the last day and a half is not really at this point. We're hoping that it does, but we don't really have any really good protocols that are defined by our shock stages. So the question is, could pressure volume loops both, one, help us define shock or aid in the management? I think if we could obtain them, the answer would be yes to the first. And the question of the second is out there. So what can we get from pressure volume loops if we could obtain them? Well, we can get very good parameters of ventricular function. You just saw that very illustratively by Dr. Burkoff. We can get measurements of load, of contractility, the end diastolic pressure, the ventricular arterial interaction with the EA. You have, could we get the measurement of EES, which is the load-independent measure of contractility, and actually truly measure contractility? We could get EDV and actually know what the LV preload is. We could get stroke volume. We could even get the myocardial energetics, as been demonstrated. But the reality is, can we get that? And this is what we walk into. And I borrowed this from Christian Bermudez at Penn. And this is an atypical, extreme example of what we have, but the reality is when we walk into this, is this a patient that we could get a lot of information from? And I have to leave it out there to the panel and to Dr. Burkoff. Is there information that we could get in this patient who's got multiple pressors, he's on a balloon pump, he's on an Impella, and the ECMO circuit? And how he got there, I don't know, but Christian does. So the other issue is, what are our current hemodynamic variables that we do have, and then how helpful are they? And again, we've had debates, and the debate will go on throughout. We have mean arterial pressure. We can get cardiac output or index. We could debate whether a FACC or thermodilution is appropriate. We can debate SCVO2 versus SVO2 as a measurement of extraction and output. We have all the parameters you can get from a PA catheter. You can get the PAPI, you can get the RA, you can get the wedge, which I think nothing else can get you. You can get your cardiac power output. You can get the CVP to wedge pressure. Or can we use TEE at the bedside? And there are places that actually put TEEs in for short periods of time, 48, 72 hours. The group at Jeff does this. And could we get parameters of load in that population? And at what cost? But the really issue is, with regard to pressure volume loops, do we actually use the information we currently can obtain? So again, we were part of the Critical Care Cardiology Trials Network. In the article by Burke, which Jeff Teutenberg showed you some of the data, we looked at 16 tertiary care centers. There's a huge variation both in the use of mechanical circulatory support and in right heart cath, anywhere from 25% with MCS to 40%, but no more than that. So what are the pressures we need to measure, and what are the other variabilities that we have? So we see a patient, they're on mechanical ventilation, they're on PEEP, they're hypoxemic, they're acidotic, they're septic, they're on multiple pressors. So can pressure volume loops help us? And the reality is, I think that yes, pressure volume loops could help us if we could obtain them and if we could get good data in a continuously variable fashion. And yes, you could get it in the cath lab, but can we get that in the ICU? And if we got it, would we use it? So I think I finished with, it was just, I think, the 100th anniversary of Dr. Seuss. Step with care and with great tact, and remember that life is a great balancing act. And I think that's what we're going to be doing in the units with all our hemodynamic parameters. I think pressure volume loops would be the basis of what we can get, but the reality is we don't use what we currently have. So I'm going to stop there, and I'm going to actually turn the questions back to Dr. Burke in our panels and whether pressure volume loops, as messy as it is, could be helpful to them in their practice.
I think that's a question that you validly asked. How can you reproduce the data? Is it constant? Is it dynamic? Because you're getting a snapshot of one PV loop in the cath lab.
Right.
What happens 4 hours from that time or 8 hours from that time? Is there capabilities of continuous PV loop monitoring? Those are the questions. If technological advance happen, maybe that is the right way. But at least it gave us some idea of unloading and different unloading parameters and devices which work. So at least that's the basis to start.
I think it is where we start. I think that the teach is actually reminding us of these parameters and of basic physiology and what we can do. I think we have to integrate it into our practice if we're able. But the reality is we're going to have a debate about pulmonary artery catheters. And believe me, I think it's criminal that a patient, and this is my end of the debate, leaves a cath lab on mechanical circulatory support without a PA catheter. And I think for ECMO, no, you don't need it in the very beginning, but when you try to wean a patient, I think it's important, or if they become congested. So for all those reasons, yes, I'd love to have pressure volume loops, maybe connected with artificial intelligence to actually put the data together and spit out some of this, but we're not there yet.
So I think that, you know, the value of pressure volume loops is understanding the physiology and helping us know how to think about, these devices and what they do and whatnot. The information that you get from a Swan-Ganz is really rich.
I agree.
And, it's not used effectively, I think, and as was heard, the training and the use of it is diminishing. But it turns out actually that if you combine the information from a Swan-Ganz and a blood pressure, you can almost construct PV loops. You don't need to have the actual devices. The one thing that we miss is the end diastolic volume, but I think that you can get by pretty well if you have an echo and an ejection fraction. I think that we can figure that out. So we've been developing a lot of algorithms for taking SWAN data in our TEACH program, in our Harvey simulator. You put in your right heart cath data, and if you know ejection fraction, it will draw a reasonable pressure volume loop. So these are things that could be, these theoretical constructed PV loops would probably be very close to the reality without the need for additional hardware and technology. And could, if you imagine at the bedside that you actually had a PV loop going that was reasonably normal, you would maybe know a little bit more about where you started and where you're heading, the effects of drugs, is the afterload, how much is the contractility kicking in, et cetera. So, but I think the SWAN has such rich data that I'm not 100% sure how much would be added by PV loops.
Well, I think I look at the ventilators as one of our speakers yesterday, the pulmonary person, talked about having the lung mechanics visualized on their ventilator, and you can go and see that on some of the newer models. That what you were talking about, I think, if we could get that would be very helpful, and maybe making a more richer picture of it rather than just hard numbers, but the loops themselves derived from a PA catheter would be very helpful to the management.
Dr. Burkhoff, I think PV loop still has a role because P is not equal to V in diastolic dysfunction, especially in AMI shock. You're basically having elevated, so if you look at the PV loop, the diastolic pressures are high. So if you assume that LVEDP is equal to LVEDV, you're going to have a problem. So,
No, I think the way to do it is, this is getting a little technical, but the end diastolic pressure-volume relationship is pretty static. So if you can, at one point in time, define the EDPVR, and there are methods for what we call single-beat EDPVR estimate, that if you can define that EDPVR and then that becomes fixed, then all you need is P, because you'll know where V is kind of tracking. So there are ways, to estimate these things. But it all comes down to proper measurements by the PACC.
And just to mention that the newest iteration of the impeller pumps have at least an estimated LVEDP, yes. And that could, in theory, be very, very helpful, because then you have the pulse pressure, you see what is the contractility, right? And you have an LVEDP, and you can say, do we need loading, do we need less loading? And that could, in theory, become very, very handy. So we just started with that, so.
I agree with you, and the problem goes back to using the data. We have a rich amount of data already, and we have more from the Impella, looking at those systems. The question is, are we going to use it? And, that's really the hard part.
So, I just wanted to mention, I'm over here. Hi. Keep looking. You
Middle.
found me. Wait, you
Middle
got
back.
it. Okay. No, just along the lines of, we have data, are we using it, and throw into this discussion. So, if I'm on consults and I have a patient presented to me and my fellow says, the echo just came back, read, and it's a ejection fraction of 20%, and the ventricle is non-dilated. And I say, well, depending on what the heart rate is, you just told me that the patient's in cardiogenic shock. And not linking it up to say, well, stroke volume is really important. And, so usually end diastolic volume maps with ejection fraction, but if it's not mapping, then probably you're dealing with a very low stroke volume.
Dr. Benitez.
I just want to make a comment regarding this one, and I agree 100% with this one. We need this one in those patients, particularly patients struggling from advanced cardiogenic shock on Impella or in ECMO. The problem we have, we're putting devices on a patient, and we don't know how to move them and how to wean the patient. Most of the hospitals have protocols how to wean, based on hemodynamics, based on echo, based on what. There's no published data on that, and everybody do what you want to do. Somebody's coming and reducing the Impella from 6 to 2 and say, okay, the blood pressure is okay, we can wean. We don't have protocols for that. And I think probably we have here to think about that and see how to establish protocols, when to wean, how to wean, when to consider the patient for the weaning. That's as important as placing the patient on ECMO or Impella. And that's still lacking, and we don't have a standardized protocol for that. That might help us also to improve the results from the devices we have, because might be the devices are doing the hemodynamic effect that's intended to do, but what we are not doing afterwards is how to manage them, when to wean them, and when to start with the escalating therapy if it's required.
Well, this is my problem with interventional cardiologists, me being one, is that they put the device in, but then they don't worry about the rest of it. So I think we have to be part of the continuum and be respectful. The same thing, I'm going to take my surgeons to task a little bit. We're very good. They don't mind me putting the patient on ECMO. They're going to be following them. I can go down and see the patient in the cardiothoracic unit. I can try and wean, but the reality is something, well, we think he's ready. We did an echo. We turned it down 20, 30, 40 seconds, a minute, as long as the perfusionist would not start screaming that the circuit's going to clot. Then we turned it back. We're going to decannulate him. And I said, okay, does he have, what's the swan? And, how are we going to manage the patient after? Because then they go right back up to the cardiac ICU. So I agree with you. We need protocols. Thank you very much.
Thanks a lot. It was great debate.